clindamycin in Clostridium difficile colitis. Since I am working in a gastrocritical care and liver transplant unit, we come across a lot of cases of this C. diff infection. So, patient who is having severe infection leading into the toxic megacolon or perforation leading to the sepsis and organ failure, this is very, very demanding because this is a simple thing to treat, but if you are not able to detect at time, it will be totally a disastrous situation. So, what is Clostridium difficile? We know this is a gram-positive spore-forming bacteria, and this Clostridium difficile causes nearly almost 5 lakhs infection and causing 29,000 deaths in the United States. So this C. diff infection that is basically causing the colitis involving the colon only. It do not affect the other part of the body, and this may be mild, moderate or severe. Either type of the colitis we can see in this Clostridium difficile infection. What is the development? The first it is being described in 1935 as a gram-positive anaerobic bacilli. Then it's come into a nomenclature that is difficult Clostridium because it was difficult to grow in the culture, and found in the stool specimen from the healthy neonate, leading to the misclassification as a commensal organism. Then in 1970, the term clindamycin colitis, that is pseudomembranous colitis in hospitalized patient. Also, but it's finally in 78, the Clostridium difficile recognized as a causating organism. We are discussing for Clostridium difficile colitis, causing what are the role of oral vancomycin. Simple drug, but if you are not diagnosing at accurate time, it may toxic megacolon, perforation and sepsis. Yeah, throw to hospital and underdiagnosed thing, and presenting into toxic megacolon sepsis shock, that will be a great thing to deal with, huge thing. And source of infection is anything in the soil, air, water, human, animal feces, everywhere it is. So you have to keep your eye open. Pathogenesis is very simple. There is a disruption of normal colonic flora, colonization with C. diff, and production of toxin A or B. Usually both the toxins are produced by the bacteria in most of the time, but in some cases, in 30% of the cases, there may be a single toxin. And there is a mucosal injury and inflammation leading to this sort of severe colitis, and as I have told you, it's maybe a cause of toxic megacolon and totally sepsis and shock in ICU patient as well. So mild disease, simply a pain abdomen, fever, loose stool like the things. Moderate disease, patient is having dehydration feature, but in severe cases, severe leukocytosis and renal failure is the characteristics one. So what are the signs and symptoms of severe cases? Basically, yeah, I will show you the chart in the management part. So these are the non-specific symptoms, but most of the patient is having watery diarrhea and pain abdomen, severe dehydration, renal failure, loss of appetite, swollen abdomen due to ascites, weight loss. But in critically ill patient, what we get, it is stool, and stool, sometimes blood mixed stool, and you are unable to control the diarrhea and you are intubated, ventilated or critically ill patient. In that case, in evaluation of diarrhea, we send a Clostridium difficile, or you test the stool for comprehensive panel, you get this C. diff organism positive. So diagnosis is, if you do the endoscopy, you can get the pseudomembranous colitis, but if you have already treated your patient or patient in getting the mildest symptoms, you may not get this pseudomembrane formation. So pseudomembrane may not be there in a classic, if it is not a classical case. And if you get the biopsy and do the culture, it is one thing, but most important is the toxin identification. So by toxin, C. diff toxin is the way you can usually send a sample and you get very rapidly, and you can identify with the nucleic acid amplification test. So NAT is the choice, and we can diagnose this very quickly. Another new strain, that is type 3, that is unseparate production of toxin A and B, and associated with presence of binary toxin, increased resistance to clindamycin and fluoroquinols, potential for the increased complication and adverse effects. This is a totally new strain, and we will discuss what are the modalities available. These are the common antibiotics after the use of which you can think for C. diff, that is clindamycin, cephalosporin, penicillin and fluoroquinols. So now the oral vancomycin. This is something oral vancomycin. I think nowadays it is being only being used for this Clostridium toxin colitis. So this is how it will be used in initial non-fulminant infection. If it is an initial non-fulminant infection, vancomycin usual dosage 125 milligram 4 times daily. Usual duration is 10 days. If delayed response to the treatment, a longer treatment up to 40 days is considered. And if your patient are in another antibiotic, then you may have to extend the course for a week after the completion of this antibiotic. If it is a recurrent non-fulminant infection, but it is a regular problem. Once we have treated, again patient is admitted with the same bug and there is a recurrence. In recurrence cases, apart from this 125 milligram post time daily, some expert reserve the patient who didn't receive vancomycin for the initial episode. So usually we extend the days of treatment that usually we give for the 2 weeks, and if the antibiotics for a primary infection, that is very, very important. You have patient is already in other antibiotic, then additional 7 days course is indicated. This regime is very much useful in recurrence cases. That is pulse taper regime. Pulse taper regime means 125 milligram 4 time daily for 2 weeks, then twice daily for 1 week, then once daily for 7 weeks, then every 2 to 3 days, 2 to 8 weeks. In that manner, if you are giving for a week like a steroid, 4 times, 2 times, once, then alternate day, then recurrence rate is, we find the recurrence rate is low. Now the fulminant infection, what we are talking about, if patient is having ileus, megacolon or hypotension shock, where we can place this vancomycin, oral or via nasogastric tube, 500 milligram 4 times daily with IV metronidazole. In this case, fulminant cases. In non-fulminant cases, you hardly use metronidazole IV because oral vancomycin is suffice. But in fulminant cases, the addition of this metronidazole is there, and duration of therapy is similar 10 to 14 days, and additional 7 days may require. If your patient is having ileus, in that case there is no bowel movement. In that case, rectal retention enema, that is, it is basically off-label use of the route. 500 milligram in 100 ml of normal saline, retained for as long possible, and to be repleted every 6 hours. So in ileus case, when you are unable to give with the mouth, the retention enema is the choice with some higher dose. 500 milligram we are using for the enema part. Used in combination of oral vancomycin and IV metronidazole, what we have discussed. Optimal regime is not established in this case, in case of ileus. And rectal vancomycin should be reserved for the patient who have not responded to the stent duration, usually 10 days we used to give. And this part of prophylaxis, which is also off-label use. For the prophylaxis, if you think your patient is high-risk patient, more than 65 years of age, and immunosuppressed patient, or having infection in last 3 months or recurrent infection in a year, in that case you can give 125 milligram once daily, continue for 5 to 7 days after completion of your systemic antibiotics. So this is for prophylaxis. Now the last part of my discussion, it was for we have discussed about the vancomycin, because it is most commonly used drug, vancomycin and metronidazole, for the treatment of Clostridium difficile. But what the literature says in the management of Clostridium difficile, I will show in 2-3 slides. In initial episode, if it is non-severe disease or severe disease. Non-severe means if white blood cell count, total count is less than 15,000 and creatinine is less than 1.5, it is classified as a non-severe. And if it is more than 15,000, creat more than 1.5, it is called severe disease. In either of the case, the antibiotic choice, the recommended antibiotic, latest one, that is pyridoxamicin, 200 milligram orally twice daily for 10 days. Vancomycin definitely is the alternative, 125 milligram 4 times daily for 10 days. For non-severe disease, alternate regime, if above agents are unavailable, then metronidazole 3 times daily for 10 to 14 days. So usually, metro and vanco is the thing, but if you have the pyridoxamicin, you have the better option because they have a sustained result. If it is a recurrent episode, what to do? If it is a first recurrence, then again the pyridoxamicin 200 milligram twice daily for 10 days, or 200 milligram twice daily for 5 days, followed by every other days for 20 days. So we are prolonging the treatment not for 10 days, for the 20 days. And vancomycin, similarly, what I have told you in the pulse manner, like 125 milligram 4 times, then 2 times, then 1 time, then alternate day, so that you are making the things prolonged. Adjuvant treatment, it is also the newer one. That is, you can give this bezlotoxumab 10 milligram per kg intravenously, given once during the administration of standard antibiotic regimen. In difficult to treat situation, you have the adjuvant therapy. If it is the second or subsequent recurrence, what we'll do? After the first recurrence, if it is the second, again, the fidaxomicin for 10 days or for 20 days, what we have done, vancomycin in pulse regime or vancomycin with rifaximin. That is the one option. When vancomycin you are giving for 10 days and rifaximin 400 milligram 3 times daily for 20 days. That is the recent recommendation. And again, in the second or subsequent recurrence, adjuvant treatment with bezlotoxumab, that is 10 milligram per kg intravenously given during the administration of standard over. Now the role of this FMT come. The fecal microbiota transplantation is the option in difficult situation. We in our institute in Apollo, I'm in Apollo, Kolkata. So we have the FMT facility, and we have given in some patient of IBD and some patient of CD also difficult to treat patient, and it is very, very good therapy. But yes, it is till now it is recommended as adjuvant therapy, not as a primary therapy for this. For the patient who have received the appropriate antibiotic treatment for at least 3 episodes, who subsequently present with a 4th episode, in that case, FMT is the choice along with the standard antibiotic regimen. Now the last slide, that is the fulminant disease. Fulminant we call if patient is having hypotension, ileus or toxic megacolon. In either of these situations, it is fulminant. And in that case, if there is no ileus, in that case, enteric vancomycin plus parenteral metronidazole is the drug of choice. 500 milligram orally or via nasogastric tube 4 times daily. Here we increase the dose. It is 500 milligram and metronidazole is 500 milligram every 8 hours. And if patient is having ileus, when you are unable to give the oral therapy, then FMT or rectal vancomycin, as we have told, 500 milligram and 100 ml of saline, put it for as much possible for 6 hours and repeat it 4 times a day. Thank you. This is a very small topic, but I think pertinent topic, because in day-to-day activity we got with the diarrhea patient in the critical ill patient. Sometimes we miss it, sometimes we are able to diagnose. Because usually we send the comprehensive stool panel for comprehensive panel and we get the toxin A or B positive. In some cases we have the luxury to go for the sigmoidoscopy or colonoscopy, take the biopsy, and from the lab they suggest that it is a Colistrium difficile infection.
Do you get fidaxomicin in Apollo Pharmacy?
Yes, you can get it. But you have to order it in advance, or you have to ask them to keep some things.
Is it expensive?
Yeah, expensive. All the biologics is above 40 to 50,000. But it is a single dose therapy, you can take. Now, Vanco and Metro is the commonest one. Only thing is not the treatment part. Vanco is the drug of choice in most of the studies still now. Yeah. The message is that since I am working in GI critical care, we have a lot of GI patients, and we sometimes miss diarrhea. If you are, no, that's we got it. That is not the issue. Issue is that your patient is having a toxic megacolon, or patient has perforation, or patient is having sepsis, and you just miss a dose of vancomycin. That time you feel a guilt. If your suspicion is very high, nothing to harm in starting empirically. Your oral vanco is not absorbed systematically, so there is absolutely no side effect. It will not be useful. Yes, because if you have the suspicion in your mind, yeah.
It takes 48 hours to come.
Yes. Now, if you have the net, nucleic acid amplification, the same day you can get it. Pardon? Yeah. Yeah, sensitivity is basically 70%, specificity is almost 100%. So that is the thing. Usually you miss in the biopsy because if pathologist is not so expert in this biopsy thing, that is the problem.
Once you start concomitant, then if you resend, it will come negative.
No, it is not like that. Yeah, after few periods, after 72 hours, it will be negative if it is working. Yeah,
What do you do for PPI? Because
PPI.
acidic diarrhea, because PPI is a hard.
Most of the antibiotics, including even the PPI, is a bad thing for today.
Take off the PPI or
No, we have to give. In ICU, at least we have to give. In OPD patient, you may not have to give all these things. Then no, it's not like that. PPI, standard PPI proton pump, you take the choice. Thank you for your nice one. Thank you.
আপনি আছেন তো স্যার, ডক্টর স্যার তো আপনি বলেছেন, স্যার আছে।